Please, we'll start our second session. The first talk will be about non-arthritic ischemic optic neuropathy by Dr. Lee.
To prevent it and to summarize the status of the various treatment options, which is none, but some are emerging and some are controversial. So the prototype is an elderly patient, middle-aged elderly patient, can be either gender, in this case male, with hypertension and diabetes, so they have vasculopathic risk factors. As opposed to optic neuritis, they're older. As opposed to optic neuritis, they don't have pain without movement, although they can have some pain. So it's usually acute painless loss of vision. And in this case, in the right eye, it's count fingers. The left eye is normal, 20/20 vision. There's an afferent pupillary defect, and the nerve is swollen, and an inferior altitudinal field defect. This is the classic presentation. So the patient is seen by had a stroke in the optic nerve. There's no treatment and nothing can be done. Our friend Simmons LaSalle in the United States would call this diagnose and adios. But there are things that can be done, and what you're trying to do is prevent it from going in the other eye, and also modifying modifiable vasculopathic risk factors that might prevent risk of stroke or myocardial infarction. Even though the disease itself is not a predictor of this, I think the risk factors should be treated regardless. And my friend and Peter's colleague, Dr. Surgott, has these H's, and I'm going to share with you Surgott's H's. The H's are, for non-arteritic AION, hypertension, but also hypotension. And Dr. Haley at the University of Iowa, where I was previously, suggested that nocturnal hypotension, low blood pressure at night, is a putative risk factor for the development of the condition. We all experience this nocturnal dip. When you lie down, your pressure goes down, and when you're not doing anything, your blood pressure goes down. And it can range from 7 to 20%. So if you believe the nocturnal hypotension theory, it is one of the causes of AION. And patients often report that they have their vision loss when they're awake. So presumably it occurred at night. Hyperglycemia, that's diabetes, or hyperlipidemia, either hypertriglyceridemia or hypercholesterolemia. The homocysteine story is still being debated and is controversial, but hyperhomocystinemia is a risk factor, presumably for thrombosis, and even though thrombosis has not been shown in AION convincingly in the non-arteritic form, we consider it a risk factor. Hypoxia, hyperperfusion, or anemia, manifesting as a low hematocrit. Hypersomnia, by which I mean obstructive sleep apnea. And then there's certain cases from post-surgical cases from cataract extraction and refractive procedures where elevated intraocular pressure has been implicated as the mechanism. So these are the H's, and I like the H's because it helps me remember what I'm supposed to tell the patient. So what's the cause of non-arteritic anterior ischemic optic neuropathy? The short and the real answer is we don't know. Even though it's presumed to be ischemia at the posterior ciliary artery level, and in this diagram from Dr. Hayes, an anatomic drawing, there's really been no demonstration that is a thrombotic event, and so any extrapolation we make from cerebrovascular disease and stroke is probably a stretch. And I just want to share with you some of the risk factors that we are seeing in the United States that you are going to be seeing, if not already here, in your part of the world. And this guy's going to take the escalator on his way to the 24-hour fitness center. He's got his towel with him even though the staircase is right next to him. Probably drove around the parking lot 3 times to get the closest spot. And I want to show you the dangerous trends that are occurring in the United States and then show you what's going on in your part of the world, even though you probably already know this. So this is obesity. Obesity defined as a BMI greater than 30 or 30 pounds overweight for a 5'4" person. And if you just follow the color codes, in this case, this is the United States of America in 1985, and you can see most of the country is in the blue zone. And we're just going to walk through the years 87, 88, 89, and a new category was created, that's at 20%. So Louisiana and Mississippi, the 2 states at the bottom there, are getting to be more obese, 20% obese. 92, then the whole south of our country, the Midwest. 96, the whole swaths of our country are obese. 1997, greater than 25%. 1998, the whole south, including my state, Texas. The whole Midwest. Now Mississippi, again, leads the way, greater than 25%. 1 in 4 is obese, not overweight. If you just put overweight, these numbers are double. West Virginia, Alabama, 2003, the whole South, new category, 30%, 1 in 3 individuals in the United States is defined by BMI as obese. Louisiana, Mississippi, West Virginia. And then the whole South, the rest of our country. And the global obesity forecast for world population is in the billions of obese patients, and you can see the projection there. I don't know what happened to the pointer. Someone keep it. And I just circled the part for the global obesity problem in your part of the world, and the Middle East is the one that's in the circle here. Peter comes to the rescue as always. So here's the Middle East. You can see overweight, and on top is obese. This region of the world is leading the global obesity epidemic. And this is the estimated prevalence of diabetes in 2007. I don't need to tell you this. The red zone is bad, and you can see where the problem is. Diabetes, obesity, hypertension, and non-arteritic anterior ischemic optic neuropathy is coming to your town, and there is no concomitant increase in the number of neuro-ophthalmologists that are serving your area. If you just look at obesity and diabetes, there's clearly something different about certain populations, and you can see the numbers for Saudi Arabia, UAE, Bahrain, and Kuwait. Big numbers for obesity and the concomitant rises in diabetes. So what I'm trying to tell you is the garden variety of non-arteritic anterior ischemic optic neuropathy is going to increase. But there's also going to be an increase in two other types of AION that you need to know about. The first is kidney disease from diabetes and hypertension, end-stage renal disease and dialysis. And when you're on dialysis, as you know, the fluid shift that occurs during the dialysis can produce hypotension. They're already anemic and can produce anterior ischemic optic neuropathy. In addition, being obese is a risk factor for the development of spine disease that often leads to surgery, and cardiac disease that leads to surgery, and both of those surgeries, spine and other non-ocular surgery, especially cardiac surgery, can result in postoperative or perioperative ischemic optic neuropathy. So all three forms of ischemic optic neuropathy are going to be increasing because of the obesity epidemic. I want to tell you a little bit about what I do for intra-dialysis hypotension-related ischemic optic neuropathy. Most of the time we just see it and we say, yeah, it was your dialysis. But and this is not evidence-based, okay, and I'd be interested to see what my colleagues are doing. But what I tell my dialysis patients who have had this already or who experience hypotensive episodes during the dialysis is to tell their renal doctor that I'm going to send them a note. And what we recommend is that the ultrafiltration rate should not be excessive and should be individualized for the patient. And 70% of the patients who have dialysis have some critical empiric blood volume threshold at which they experience hypertension symptoms. And they will tell you this. I feel woozy at X, 3/4 through the dialysis, or whatever. And that threshold can be estimated from the ultrafiltration rate. And they can determine whether it can be optimized higher or lower. In addition, we can change the dialysate sodium concentration to alleviate or at least make less the hypertension that occurs during the dialysis. And we can lower the temperature of the dialysis temperature. 35.5 is the recommendation. By decreasing the core temperature and by adjusting the energy transfer over the extracorporeal system, we might be able to impact the risk of the development of non-arteritic anterior ischemic optic neuropathy from intradialysis hypotension. This is not proven. I'm just sharing with you my individual recommendations. For the surgery, and I mentioned to you that obesity is going to increase the two surgeries that are most commonly associated with ischemic optic neuropathy, that's spine and cardiac surgery. This was looked at by a task force. Ian Miller and Nancy Newman were on this task force in the United States, as well as anesthesiologists, surgeons, and orthopedic surgeons and anesthesiologists for neurosurgery. And in the U.S., because of the medical legal risk, we probably should be consenting the patients for the risk of postoperative vision loss. There's an indwelling arterial catheter to measure the blood pressure, and I recommend consideration for a central venous line. We're going to recommend colloid over crystalloid volume replacement therapy because that keeps the blood pressure a little higher and doesn't cause the hemodilution effect as much. The head should be equal to or above the heart level during the surgery. And if it's going to be a multiple-hour procedure, we recommend staging the procedure into 1, 2, or 3 stages. In the literature, there's significant variability in the presumptive risk factors, hypotension and anemia, and there's no evidence-based recommendation that can be made for hematocrit threshold or blood pressure threshold. I'm just telling you what the task force has recommended up here. This part is not proven. Other treatments have been recommended. Steroids, and I know that Dr. Savino and I probably will disagree on this one, and can debate the merits of this in the panel. Corticosteroids are useful for the arteritic form. That's clearly standard of care, but have also been proposed for the non-arteritic form of anterior ischemic optic neuropathy. I think this is an interesting hypothesis because maybe the steroids work not because of any ischemic mechanism, but because of reduction of edema or neuroprotective effects. We really don't know what the mechanism by which corticosteroids could impact non-arteritic anterior ischemic optic neuropathy. But Naion has been touted because of its neuroprotective effects, alpha-GAN in particular, have no proprietary interest, unproven. Aspirin, I give my patients an aspirin today because of the risk of myocardial infarction and stroke. The data is conflicting about the reduction of risk to the fellow eye. I already mentioned corticosteroids, which is controversial. Levodopa has been looked at in a small sample size series twice. It's unproven in my opinion. I already told you about surgery, which is not recommended. And there are scattered case reports of transvitreal optic neurotomy, putting an MVR blade directly into the optic nerve head to release the quote-unquote compression syndrome. This is unproven. So let me just show you the one I do kind of think merits discussion, which is steroids. Dr. Hayray performed a retrospective patient choice study, which meant the patients were offered steroids if they had non-arteritic AION. The biologic rationale for using steroids in an ischemic condition is unknown, but might be neuroprotection or might be membrane stabilization. Pick your favorite mechanism of steroid. This was not a randomized trial, but in this study, patients that were treated with steroids within 2 weeks of onset who had 20/70 or worse vision had a better visual field and acuity outcome. I think it's interesting for generating a hypothesis, but the only way to test this hypothesis is by performing a randomized clinical trial. I do not have this data for you. I just have hypothesis generating data. So what do I tell my patients who have non-arteritic anterior ischemic optic neuropathy? I tell them about this Hayray study. I explain to them the difference between a patient choice study, retrospective, which was what this was, and a prospective randomized clinical trial. I dissuade patients who have high risk of developing steroid-related side effects from the steroids, but I still tell them that it exists. And I offer it to patients who meet the protocol from Dr. Hayray's study of 20/70 or worse vision who I have seen within a week of onset of vision loss symptoms. I also offer it to patients who are monocular or who have severe vision loss as a desperation measure. But the bottom line is, on all of these treatments, there is no proven effective therapy for non-arteritic anterior ischemic optic neuropathy of the garden variety type. So here are the 10 things you can do. One, I always contact their internist or family practice doctor to treat and evaluate the vasculopathic risk factors, the SIRGOT H's, hypertension, hyperlipidemia, and hyperglycemia. I tell them to stop smoking, and I give them the option of an aspirin per day if there's no contraindication for the cardiovascular benefits. I want to tell you about the smoking thing real quickly. This is Patrick Reynolds. Patrick Reynolds is an anti-smoking advocate in the United States. He has a foundation for a smoke-free America. His father died from smoking-related COPD. His brother died from smoking-related COPD. His aunt died from stomach cancer from smoking. His grandfather died of pancreatic cancer. All were smokers. That's not the interesting part. Patrick Reynolds is anti-smoking because Patrick Reynolds' dead brother was R.J. Reynolds III. Patrick Reynolds' dead father was R.J. Reynolds Jr. Patrick Reynolds' dead grandfather was R.J. Reynolds. R.J. Reynolds makes these cigarette brands. 2 billion smokers worldwide, of which 200 million will die from smoking-related illness. So Patrick Reynolds goes around with marketing material to demonstrate the dangers of smoking. And there is clear evidence that a physician telling a patient to quit does make a difference. 39 different trials of the effect of doctors telling 31,000 people to quit smoking. And being hounded by their doctor to quit smoking made the people almost twice as likely to quit. An extra 2.5% of tobacco addicts quit in this pooled meta-analysis just based on their doctor telling them. In young people, I look for additional risk factors. One of the risk factors is drusen. Drusen presumably can relate to the compressive syndrome at the optic nerve head, whatever mechanism you want to invoke. I think it's useful to identify it so they don't end up with a hypercoagulable state workup or some other thing that's unnecessary. Oops, went the wrong direction. I also asked them about snoring and excessive daytime somnolence. Obese males are especially at risk for this, and there's clearly been an association between sleep apnea and non-arteritic anterior ischemic optic neuropathy, and a sleep study might be useful in that setting, not just for the eye, but for their cardiovascular risk factors and their general health. I also tell them about alcohol at night. Obviously, this might not be a problem here in Kuwait, but alcohol in the United States clearly potentiates orthostatic hypotension, and if you believe the nocturnal hypotension theory of Dr. Haley, it makes it worse. There are other medicines that people take at night that they don't know are antihypertensives. Diuretics, tricyclics, vasodilators, including medicines that are being used for prostate disease, and sedatives to help them sleep. There is also in the United States a prospective study, observational cohort, to determine whether the erectile dysfunction agents, including Viagra, cause anterior ischemic optic neuropathy. This has not been answered yet. Minoxidil, which is marketed for hair loss in the United States, was an antihypertensive when it first started. And I already mentioned to you about alpha blockers and sleeping pills. I don't waste any money on extra tests. I do not perform hypercoagulable state workup. I don't do a cardiac echo because it is not an embolic disease. I don't do any carotid studies or imaging their head. The only thing I consider doing is I do look at antiphospholipid antibody and hyperhomocysteine in young patients, young being defined as less than 40 years of age with no vasculopathic risk factor, but there's no evidence base to support what I just told you. But the most important thing, and the thing I really want you to take home with you, is don't say nothing can be done. Because, number one, there are modifiable risk factors, and we can try to make this obesity epidemic less if we do something about it now. Reassure the patient, educate them, and give them hope, and offer no vision services to appropriate patients. I make sure to watch the patient to make sure the disc edema goes away, because if the disc edema doesn't go away, I'm going to image that person. About once every 3 months, I'm sent a patient who has a sheath meningioma that was sent to me as anterior ischemic optic neuropathy. So in summary, what are the things you can do for non-arteritic AION? Control the vasculopathic risk factors called the internists. Aspirin per day with no contraindication. In young patients, I do an ultrasound looking for buried disc drusen. I ask about excessive sleepiness or snoring, and I do a sleep study if they answer yes for obstructive sleep apnea. We need to correct this obesity epidemic because it's going to cause downstream problems, diabetic retinopathy, ischemic optic neuropathy, and it's going to increase spine surgery, dialysis, and cardiac surgery. Lose weight, eat right, exercise, don't smoke. Things that you should be doing for yourself and your family members as well. In the U.S., we tell them not to do the nightcap thing, that's a drink at night, and I advise them to take their medicines in the morning, their antihypertensives, as well as the other medicines that can produce nocturnal hypotension. There are other medicines, in addition to that, minoxidil, erectile dysfunction agents, other medicines that should be on the list. I do a limited hypercoagulable workup in non-arteritic AION of the young, but I do not do carotid Dopplers and echoes. I reassure them and answer their questions. And I thank you for your time and attention.
Thank you, Dr. Lee, for this interesting talk.